Hi, I'm Dr. Andrei Shustov. I'm a medical oncologist at the University of Washington, and I specialize in treatment of lymphomas. A particular focus of my clinical practice and research is a rare and diverse group of lymphomas called T-cell lymphomas or peripheral T-cell lymphomas. Today, I will discuss the general principles of management of T-cell lymphomas that can be applied to other hematologic cancers. There are three very important aspects of lymphoma treatment that are exquisitely important to discuss with your doctor and understand before you start treatment. First, cancer therapy in general, and lymphoma treatment in particular, are risky. The medicines that we use, chemotherapy drugs, are pretty toxic, and you have to be ready to undergo intensive therapy and require support from medical team, family, friends to successfully emerge on the other side after treatment is done. Second, real-time assessment of risk-benefit of your treatment is very important. Therapy might affect your health, your organ functions, and even though it seems at the beginning that you can tolerate treatment, 2 or 3 steps into the therapy, you might discover this treatment is not for you. Real-time, step-by-step assessment of risks and benefit of your treatment, that's something that has to happen all the time through your journey. Finally, defining goals of care is very important in choosing the right therapy in the right direction that you go in your cancer treatment and lymphoma treatment in particular. In the next couple of minutes, I will demonstrate how these aspects apply to other principles and specific lymphoma treatment. Over the past 30-40 years, several modalities became very important in cancer treatment in general and lymphoma treatment in particular. The very first treatment for cancer was surgery. Some patients with early-stage cancers could be cured by just removing the tumor from the body. But this only applies to a small proportion of patients. In many cases, tumors already hiding in different places. You cannot just remove it from one place. Radiation was the first type of treatment that emerged and cured patients with early-stage lymphoma besides surgery. This was the first big success of lymphoma therapy. Finally, chemotherapy came along and allowed us to treat lymphomas and cure lymphomas even with advanced stages. In the last several decades, a lot of work was done, and finally we're harnessing the results of that work in developing what we call biotherapy, targeted therapy, as well as utilizing your immune system to help us fight your cancer, or immunotherapy. As a general rule, cancer treatment was evolving from more toxic and less efficacious to less toxic and more efficacious. We are finally on the edge of moving cancer treatment where we will combine less toxic biologic targeted drugs, maybe with immunological drugs, and leave behind any chemotherapy, any radiation that will provide us with curing your lymphoma, curing your cancer without too much toxicity and greater success. I'd like to introduce several principles that I discuss with patients that are very important to understand because they underlie certain regimens, they underlie principles, they underlie the whole management strategy that we discuss with patients in the first day or before we start treatment. As I mentioned, chemotherapy, the most commonly used modality to treat cancer, is targeting rapidly dividing cells. Once again, why is it true? Or why do we employ that principle? By definition, cancer cells have infinite life and they divide all the time. So if you don't stop cancer, it can keep growing for decades and decades and decades. Usually it doesn't happen because it has detrimental effect on the human body. But this constant division cycle of cancer cells can be utilized to employ certain treatments to stop it. So chemotherapy drugs, as a rule, affect cells that are in the middle of the cell cycle. We use the difference between how often normal cells divide and cancer cells divide to determine the window where chemotherapy drugs would not harm the normal cells, but would detrimentally affect the cancer cells. That is called therapeutic window. The challenge defining therapeutic window is that there are a lot of cells in our body that still have to divide constantly throughout our life. The best example is the bone marrow. Our blood cells are renewing every day. So the blood cells have to be produced on a daily basis. And where it happens is the bone marrow. So if chemotherapy affecting rapidly dividing cells, the first organ that toxicity is going to be falling on is the bone marrow. And as you probably aware, that affects the blood counts. So the most common finding, the most common toxicity of all the chemotherapy drugs is low blood counts. And this includes platelets, white blood cells, red blood cells. Why? Because they have to be produced by bone marrow all the time. The second example is hair follicles. In order for hair to grow, cells in the hair follicles have to divide all the time. Hence, patients undergoing chemotherapy frequently lose their hair. The other example could be the cells in the intestinal tract. When we eat food and we process food, the cells that are lining the intestinal tube, they're being sloughed off all the time. They have to be replaced. And they're replaced by constant division of the cells in the gut. If we interrupt that process, that affects the health of the intestinal tract, and hence nausea and vomiting and gastrointestinal side effects are also among the most common in chemotherapy. All of this comes from this first principle that we are targeting rapidly dividing cells. We have learned that if we use one drug at a time, cancer cells can develop resistance. They can figure out how to either pump out that medicine out of the cell or mutate so the drug doesn't work anymore. Then treatment would fail. Therefore, we combine multiple chemotherapy drugs into what we call regimen or protocol to affect the cancer cell growth from multiple directions and leave less a chance that cancer cells can figure out how to get out of the toxic effect of chemotherapy. That's why we have to combine multiple medicines together. Every time we do chemotherapy, some of the cells in a tumor are not dividing at that particular time. You receive the infusion of chemotherapy drugs, whether it's one, whether it's multiple, 2-3 days, they're out of your system. That means that cancer cells that were sitting there and not dividing during those 3 days are not going to be affected. So we miss them. So that's the fraction of the cancer cells. Once you're done with the cycle, going to start growing back. How do we overcome this? We do multiple cycles of treatment. Every time patients receive treatment, we kill certain proportion of cells that are in the cycle, that are dividing. The ones that left behind, we have to come back and hit them again. Hence the principle of multi-cycle therapy. Chemotherapy is pretty intense. These are medicines, as I mentioned, that affect the livelihood of dividing cells. Besides the example I gave you a couple minutes ago, there are certainly other cells in our body that are affected, whether because they're dividing or direct toxic effect of chemotherapy. So going through treatment, patients would require a lot of supportive care. That's a term that we outline multiple directions that we try to support your body during intensive treatment. First of all, lymphomas are tumors of the immune system. The chemotherapy drugs that we pick to cure them obviously going to affect the normal immune cells. There is not that much difference in a sense between lymphoma tumor cells and lymphoma normal cells. That is why the immune system function during chemotherapy would be significantly reduced. What does the immune system do? It protects you from infection on a daily basis. Hence, we have to support patients by making sure that they do not get life-threatening infection when the immune system is low. Some types of regimens that we use require prophylactic antibiotics. Even if you don't have any signs of infection, we have to give you treatment for such. because if we don't, there is a high risk that some very virulent bacteria, very bad bacteria virus can enter your body and make you very sick. As I mentioned, bone marrow needs support because chemotherapy interrupts that constant division of bone marrow cells. Blood counts are low, that puts you at the risk of either bleeding or infections or other complications. That's where we utilize transfusion support. Going through chemotherapy for lymphoma, it is likely that at some point in time you would need transfusion of platelets, red blood cells, or other infusions to compensate for that reduced bone marrow function. Intestinal tract affected by chemotherapy does not provide adequate absorption of nutrients when you eat. Plus, nausea and effect on GI tract reduce the amount of calories that you take. So nutritional support during cancer treatment is extremely important. A lot of patients lose weight or become weaker because we cannot compensate for that loss of nutritional intake during cancer treatment. One of the options that we always offer patients to have dietitian or nutritional physician on board, so we do not lose on that front and we maintain the health of organs by providing adequate nutrition. Side effect management is very, very important. We can only give chemotherapy to patients if we compensate for significant side effects they can develop. Nausea, vomiting, diarrhea, constipation, pain or fevers, all of those are part of the management while you receive treatment. Now, one of the most fundamental questions and principles of treatment that you have to discuss with your doctor is whether we're going to try to cure your lymphoma or we're going to try to control it. Ideally, we would like to cure every cancer, but we are not quite there yet. So at any given point during diagnosis or treatment of your lymphoma, you have to gauge whether we are curing the lymphoma or we are trying to suppress it and make sure it doesn't come back for a very long period of time. It sounds unsettling that we cannot cure your cancer, but I always tell my patients that if you think about other diseases in medicine outside cancer, diabetes, high blood pressure, coronary disease, rheumatoid arthritis, psoriasis, we're actually not curing any of those. As a matter of fact, we are curing a very small proportion of human diseases. But outside cancer, we learned very well how to control them. As long as you take your blood pressure medications, your blood pressure stays within normal range. As long as you take your insulin or sugar controlling medicines, your glucose in blood within normal range. As soon as you stop, things go in disarray. Applying the same principle to treatment of lymphoma in the situations where cure is still not possible and the toxicity of treatment is very high, the appropriate approach for those patients could be try to control the disease with less intensive therapies, still effective therapies, and make patients live longer, sometimes for years or decades, without significant side effects. That is something we call palliative intent treatment. It is very different from hospice. It's not giving up. It's not walking away from lymphoma treatment. Intent of treatment is different. It is so important that I would like to come back to this again and say if you apply the wrong intent of therapy, the overall management of your lymphoma could be going in the wrong direction and you might have a lot of side effects for no particular benefit. There are some lymphomas we can cure, maybe not in everybody, but we can try to cure it. And then we talk about curative intent therapy. The big difference between curative intent and palliative intent treatment is how much toxicity we would like to endure. Me as a physician, you as a patient, how much toxic side effects, bad side effects we can tolerate. If I told you that there is a very good chance we can cure your lymphoma, then enduring side effects, multiple side effects, cycle by cycle may be the right thing to do because at the end of treatment, lymphoma might never come back. If I told you that chances of curing your lymphoma are very low or we cannot cure it at all, Going through treatment like this and exposing you to a lot of side effects might not be the right decision. While doing one drug at a time, using biologic drugs instead of chemotherapy, or even delaying treatment as long as lymphoma is not progressing quickly might be the better way to go. That's a big difference in approaches and might really change the landscape how your particular lymphoma is approached. Again, it's very hard to overemphasize the importance of making that decision at the time of diagnosis when you talk to your doctor, or even after initial steps of therapy. I always talk to patients about the importance of family support, friend support, and a social support. Treatments that I do, my colleagues do in the treatment center, we can handle. There is a lot of medical personnel can help you with side effects and counseling, but 90% of cancer care happens when you leave the clinic. You have side effects at home, you're tired, you cannot do certain things that you can accomplish on a daily basis. Otherwise, that's where family support and friend support is so important. It is so hard to go through cancer treatment alone, and in many cases it's impossible. So we always try to harness the help of the family and work with the family all the time, bring them to the appointments, but also don't forget about friends. There are a few patients that I have whose family lives far away and they didn't feel like they can go through cancer treatment. In some situations, we find a neighbor who is willing to help. Find a friend who lives a couple blocks away. Do not underestimate the willingness of your friends, the willingness of neighbors to help you to go through that journey. You never should do it alone. It is very important to trust in your doctor, nurse practitioner team, because they are responsible for making those very serious decisions for you. But big part of it is something we're trying to accomplish today, is to educate you about your lymphoma and about your treatment so you become part of that team. When you try to fight it together, the chances are always higher. And finally, in my practice, I always tell patients that work always comes back. When you go through treatments like this, they're very intense. And if you can, take time away from work. Take time away from work when you go through treatment and after you finish treatment. It is very, very important this time of your life to focus on treating your cancer rather than try to juggle the stress of work, stress of family, and a huge stress of being diagnosed with cancer. Another thing I'd like to discuss today is a very different type of treatment that is frequently brought into consideration in lymphomas. And I will talk about the principle of autologous stem cell transplantation or bone marrow transplantation. You will hear this word and this discussion with your doctor very frequently if you're diagnosed with T-cell lymphoma. What is autologous bone marrow transplantation? From the beginning of time, when we were developing treatment for lymphomas, we realized that a certain amount of chemotherapy does not kill all lymphoma cells. So the first direction to go to was, well, how can we increase the doses of chemotherapy, bring all the power of multiple drugs together without killing the patient? The biggest obstacle was how to save the bone marrow, because the first organ, the most sensitive organ that blocks us from doing that is the bone marrow. If you give enough chemotherapy, you will wipe out the bone marrow. We figured it out. Imagine if you collect or harvest your bone marrow before you do chemotherapy. You put it in a bag and you freeze it up. Then you can do very intensive treatment just one time, one cycle of very intensive chemotherapy, sometimes chemotherapy and radiation, and hopefully kill every single tumor cell, and then bring the bone marrow back. That is what autologous bone transplantation is all about. Typically, you would receive several cycles of induction therapy, several cycles of regular chemotherapy, and if tumor proves itself to be sensitive, it shrinks and you're in remission. We would generally utilize a couple of cycles of more intense chemotherapy, and right after that, we would collect your bone marrow cells or your stem cells. Afterwards, we give patients very intensive cycle of chemotherapy or chemotherapy and radiation, hopefully kill every single lymphoma cells, but then we have to save your bone marrow. And that's when we reinfuse the stem cells collected from you before. They go back into your bones, and it becomes your new bone marrow. And 2, 3, 4 weeks after the procedure, blood counts recover, and you return back to your normal state of health. Finally, very unique form of treatment of lymphomas that is applied to some other diseases as well, something we call allergenic bone marrow transplantation. A lot of principles that we just discussed for autologous bone marrow transplant applies to allergenic bone marrow transplant, except when the time comes to infuse the stem cells, they come from a different person. Why do we do that? The very fact that lymphoma or other cancer developed in your body is because the immune system failed to control it. So putting back the same immune system that failed in the first place puts us at disadvantage in the situations where cancers are very aggressive. And that applies to a lot of T-cell lymphomas. What if we take immune system from another person and make that immune system fight your cancer for you? And that's what allergenic bone marrow transplantation is. When the bone marrow from another person is infused into your body, cells go back to your bones, they repopulate, and you have a new bone marrow, but it's a bone marrow from the donor. That bone marrow gives rise to a new immune system that is attacking your cancer, attacking your lymphoma as if it was an infection. It comes at a high price though. The same immune system might attack your body. And that's something we call graft versus host disease. It could be risky. In some patients, it brings a lot of complications and can make you very sick. That's why a discussion about bone marrow transplantation from another person is a very important one, and it is a high-risk procedure that always has to be weighed against what benefits we're acquiring by using this modality. Finally, a couple words about new developments in cancer treatment that I started with, and it is biologic and immunotherapy. We use these terms biologic therapy, targeted therapy, small molecule therapy, all of which mean that in some cancers we figure out specific switches that allow cancer cells to persist. I would use this slide just for schematics to show that the same molecules that we talked about sticking outside the cells, they can send the signals down to DNA of the tumor cells and regulate the process of constant development, constant growth. And if we develop a small molecule that can only attack this target, or this target, or this target, we can shut the whole thing down. And if this process is only operating in tumor cells, you will have no side effects on any other normal cells. That's the essence of this targeted therapy of cancer that's been developing now for almost 2 decades. Finally, big word, immunotherapy, and even more recently, CAR T-cell therapy, all describe the process where we try to harness the power of your own immune system to attack the tumor. We are trying either to re-educate your immune system how to kill your cancer, or we take the normal T cells out, your immune cells out, and introduce the weapons that they can use to fight your cancer when we put them back. This is very new, very exciting trend in cancer treatment that in the next 5-10 years might provide benefits to patients with hundreds types of cancer, millions of people around the world. This will conclude the section about principles of cancer therapy. Thank you for listening, and I hope you come back for other discussions of specific T-cell lymphoma treatments. Thank you.